Oh, I think they all will, Steve. I mean, to me, this is deja vu all over again. When drug-eluting stents came out, they were charged $3,000 a piece, and people thought they were going to break the bank. And then over time, after the second or third becomes available, the prices of these go down a lot. So I think what I've seen in my 30 years of practice is when a first breakthrough device comes out, they can charge a premium, they have a monopoly, and people just sort of eat it. When the second device comes out, there's a little bit of price constraint that happens, and then when the third one gets on the market, then the bottom falls out of the price. I mean, it doesn't cost Edwards $30,000 to build the valve. It probably costs them $2,000 or $3,000. So they're making a huge margin right now, and they say they're recouping their research costs, which I think they are to an extent. But there's really the availability to make a much less expensive valve is there. I mean, they charge $5,000 for a surgical valve. Why should they charge $30,000 for a percutaneous valve? So I think that pricing is going to be an issue. In the short term, hospitals have to be very careful because it really depends on the DRG that the patients are discharged from. DRG 216 is well reimbursed. Hospitals make money. DRG 217 is poorly reimbursed. Hospitals lose money. And if you take a look at data from consulting agencies in 2012, about 80% of the patients were being discharged in the money-losing DRG and only about 20% in the money-making DRG. So hospitals, I think, are really going to have to scratch their heads to decide whether or not it's a business that they want to be in. Currently, they lose money in 3 out of 4 patients that they discharge from the hospital. No, when heart block happens, it happens usually immediately during the procedure, or very rarely up to 3 days afterwards. But it always happens during the hospital admission. So the patients won't be discharged unless they have a pacemaker implanted. No, it's the same DRG. It's DRG 216 or 217, and they will get paid the same amount of money. Just the costs will go up. So whatever the cost of the pacemaker and the cath lab time will increase. The physicians make a little more money because that's not a DRG based, and so the physician professional fee for implanting the pacemaker will be billed to whatever professional group the physician belongs to. But the hospital loses margin by having an increase in cost for the pacemaker. Yeah, the pacemaker costs between $2,000 and $3,000. And the whole supply cost for the whole entire stay is around $50,000 to $60,000. So it is a substantial portion, but in and of itself, it's not a total money loser. I think that hospitals really have to be very proficient in how they code for these patients, and that's really whether will show whether they can make or break money. The other thing that we have to look at is over time, the American Hospital Association is probably more powerful than any other lobbying group other than the ARA or AARP or NRA. And they will work it out with CMS to get an increase in reimbursement when hospitals show that their charges have increased. I think the market potential for TAVI valves are actually quite large. We had a heart surgeon visiting our lab yesterday, a young heart surgeon that wants to learn how to do TAVIs or TAVRs. And he said to me, you know, I can see in 5 years I'm not going to be doing any surgical aortic valve replacements. So I think most of the surgeons kind of with enough vision recognize that these valves are here to stay. For aortic stenosis, it's a very good valve. It's very durable, and I think it's very safe. And they're getting better and safer. There still has to be a solution for embolic stroke because that still is, I think, the major sort of safety standpoint problem. And once that is corrected, then I think there really won't be an impediment. And so what we're going to be seeing is trials being done in lower and lower risk patients. I know that Medtronic is in discussion with the FDA right now to lower the risk pool of their patients that they're doing in their randomized trial. We know now that the device works very well for moderate to high risk patients. That was partner 1. We think it probably works equivalently. That will be partner 2. And then the next level of studies will be in low-risk patients, and that may be TAVI. And so I think what's happening is that the market is really shifting. In Europe, they can't randomize any patients to TAVI because none of the patients want to have the risk of having open heart. Everybody wants a percutaneous valve. So I think that the market is going to try to drive people towards this, and so I think the pool will expand. It's been a much lower uptake than people thought. A lot of this was driven by uncertainty about reimbursement. After Medicare released their NCD, there was a lot of question as to who would get paid for for the valves that were put in. Would people get paid if they did a transaortic access, as an example? All of that now has been clarified within the last few months. There's been a lot more clarity about exactly who is going to be reimbursed or which patients will be reimbursed. So I think that you're going to start seeing an increase. There still is an enormous appetite in the United States for opening up TAVR programs. There's probably going to be between 300 and 400 programs throughout the country, and all of those centers are going to be clamoring to do cases. So I think that's going to really drive a continuing uptake of the numbers. Well, I do worry about expanding the medical market. Whenever I comment on this, I mean, my comments seem to be self-serving, but they're not. I think that I've implanted over 400 valves already, and I still learn every time I do one. And I think that it really takes at least 100 until you're very comfortable and proficient. Not only that, but the center has to have a certain amount of volume so that the nurses and the techs and all the other staff are used to knowing how to take care of these patients and looking for subtle complications that can happen after the procedure. So I've always been a firm believer in volume outcome relationship, and the data from angioplasty, I think, is going to be even more magnified. With angioplasty, we know that the worst scenario is a low volume operator in a low volume center, and those people end up with very poor outcomes. If you're a low volume operator in a high volume center, so if you're at Columbia or you're at Henry Ford and we're doing a few cases, we've got enough staff around so that the results would probably be pretty good. But if you're in a very small community and only doing these occasionally, I think that you're going to get very variable results.